Physiology. This is Respiratory Physiology Part 7, so I managed over a year to work through each of these topics. We first talked about ventilation a little bit over a year ago, and then we talked about diffusion, pulmonary blood flow, gas exchange, blood gas transport. Oh, here are handouts for those of you who need them. Respiratory mechanics, and today we are going to talk about control of breathing. So in the first lecture of this series, we talked about ventilation, where we talked a lot about dead space and how the arterial PCO2 is determined by carbon dioxide production, minute ventilation, and dead space ventilation. Then in our second lecture, we talked about diffusion of gases across the alveolar capillary membrane. And we said that the movement of gas across the alveolar capillary membrane was determined by the area of the membrane, the thickness of the membrane, the pressure gradient across the membrane, and the diffusibility of the gas. Then we talked about blood flow through the lungs, and we talked about how the pulmonary vascular resistance is determined by the pressure in the pulmonary vasculature. So if pulmonary arterial or venous pressure increases, there is a decrease in pulmonary vascular resistance because the blood vessels dilate and there are blood vessels that are recruited. We had also pointed out that pulmonary vascular resistance, as it relates to lung volume, is this U-shaped curve, and the lowest pulmonary vascular resistance relates roughly to a normal functional residual capacity. So that in a patient with a low lung volume, such as ARDS, they will have an increase in pulmonary vascular resistance. Then we put them on PEEP, which restores lung volume. Pulmonary vascular resistance decreases, but if we put them on too much PEEP, pulmonary vascular resistance goes up, and that explains some of the hemodynamic effects that we see with PEEP. And then we had also talked a little bit about selective pulmonary vasodilators like inhaled nitric oxide or prostacyclin, which selectively improves blood flow to the ventilated part of the lungs. And the physiology of that is nice. Whether it makes any difference as far as patient outcomes and cost is another discussion outside of physiology. Then we talked about ventilation perfusion matching in the lungs. So with normal matching of ventilation and blood flow, we end up with a PO2 of about 100, a PCO2 of about 40. If we reduce ventilation, if we lower the VQ, that will be a shunt effect, and a pure shunt will be blood flow without any ventilation. And at the other end of the extreme is dead space, where there's ventilation without blood flow. And in this case, we tend to get, with a shunt, we get hypoxemia. With dead space, we get hypercapnia. Then we talked about the physiology of gas transport, and we talked about loading of oxygen onto the hemoglobin. And in this presentation, we talked a lot about the oxyhemoglobin dissociation curve and things that affect the relationship between oxygen saturation and PO2. And in this lecture, we also talked about the relationship between carbon dioxide concentration and loading of carbon dioxide onto the hemoglobin as a function of PCO2. And we had pointed out that if the oxygen saturation increases, the amount of carbon dioxide on the hemoglobin decreases. So with an increase in oxygen saturation, there is an increase in PCO2 because of the shift of this relationship, and that explains primarily why patients with COPD, for example, who are put on oxygen have an increase in their PCO2. It's because the increased oxygen saturation pushes carbon dioxide off of the hemoglobin. So, and we'll get back to this again today, the increase in PCO2 that occurs with breathing oxygen and COPD is not related to respiratory drive, and I'll show some evidence for that later on in the presentation. So it's mostly related to increased oxygen saturation, shifts the relationship between CO2 concentration and PCO2. So increased oxygen saturation moves carbon dioxide off of the hemoglobin. Then I think we had 3 lectures on respiratory mechanics. So we talked about the volume-pressure relationship, which relates to the elasticity of the lungs and the chest wall. And we had pointed out that the relationship between volume and pressure is S-shaped and sigmoidal. And we talked about how that differs for normal lungs versus lungs with ARDS. We had pointed out that airways resistance is to a large extent dependent upon lung volume. So with a higher lung volume, there is a lower airways resistance because of the tethering effect of the lung parenchyma on the outside of the airway. We talked a little bit about time constant, which is resistance times compliance. So if we have a stiff alveolus, as is illustrated here, the lung unit will fill quickly and empty quickly, although it will not fill to the same amount of volume as normal. And if we have an increase in airways resistance, this lung unit will fill slowly and will empty slowly. So this then would be a patient with obstructive lung disease like COPD or asthma. This would be a patient with restrictive lung disease like ARDS, for example, or interstitial lung disease. And then we talked a little bit about work of breathing, and the point that we had made here is the ideal work of breathing will be determined, or the ideal respiratory rate. So the ideal respiratory rate will be determined to a large extent by the work of breathing. And work of breathing is determined by resistance and compliance. So individuals who have stiff lungs, like a patient with interstitial lung disease, will have the lowest work of breathing at a more rapid respiratory rate than normal. And individuals with an increased airways resistance, like COPD and asthma, will have the lowest work of breathing at a lower respiratory rate. So why do patients with pulmonary fibrosis breathe at respiratory rates in the 30s? Well, that's because they have a decreased compliance, so their work of breathing is the lowest at a more rapid respiratory rate. Whereas a patient with obstructive lung disease will have a lower work of breathing at a lower respiratory rate. So I think that then gets us caught up to what we're going to talk about today, which is control of breathing. So here we're going to describe the role of the brainstem and the cerebral cortex in the control of breathing, compare the central and peripheral chemoreceptors, describe the role of the lung and other receptors, discuss the response to carbon dioxide and oxygen, list causes of an increased and decreased respiratory drive, describe how respiratory drive can be assessed, and then describe factors affecting dyspnea. This illustrates the neurorespiratory system, which is comprised of the cerebral cortex, the brainstem. The brainstem is the primary controller, as we'll talk about in a minute. It involves the spinal cord motor nerves and the respiratory muscles. So an issue anywhere along this path can result in reduced ventilation. So we can have reduced ventilation as a result of a problem with the central controller, with motor nerves like patients with neuromuscular disease, with muscles like muscular dystrophy, and then there are a number of receptors that feed into that system. So we then have the central controller, which is found in the brainstem. So because the central controller is in the brainstem, that explains why patients in a persistent vegetative state can still breathe. So patients can be in a persistent vegetative state and don't need to be intubated or trached or on a ventilator because the central respiratory controller is in the brainstem. And once the brainstem activity is gone, as our folks will be able to describe better than me, you are brain dead at that point. There are a number of sensors or affectors that feed into the system. These include chemoreceptors and the lung and other receptors. We'll talk about those in more detail in a minute. And then the effectors from the output of the central controller are the respiratory muscles. So the central controller is found in the brainstem, so the central control of breathing is found within the brainstem. So as I said before, one can have very little upper brain activity. One can be in a persistent vegetative state and still be able to breathe off of the ventilator because the central respiratory controller is in the brainstem. Specifically in the brainstem, the medulla and the pons are the central controllers. The medulla has a dorsal respiratory group which controls inspiration and a ventral respiratory group that controls expiration. The pons consist of the apneustic center in the lower pons, which turns on inspiration, and the pneumotaxic center in the upper pons that turns off inspiration. So what can happen with a pontine stroke is, for example, is there can be injury to the pneumotaxic center, which turns off inspiration. And how do those people breathe? Well, if this part's working and this part's not, they have what's called apneustic breathing. So they go. And I'll show a picture of that in a few minutes. So injury to the pons can result in an abnormal breathing pattern called apneusis or apneustic breathing center. And then the cerebral cortex also can have some effect on breathing, and that's the reason why we can voluntarily increase or decrease our breathing. So we can think about breathing more, we can breathe more. We can think about holding our breath and hold our breath. So that comes from the cerebral cortex. This just illustrates the anatomy here is the brainstem. So here is the pons with the pneumotaxic and apneustic center, and the medulla with the dorsal and ventral respiratory groups sitting right above the spinal cord. So again, the point is we can have very little activity above this point. So we can be in a vegetative, persistent vegetative state and still be able to breathe because of brainstem activity. And when brainstem activity is gone, then one is brain dead, and that's the apnea test, which you do over and over. The central chemoreceptors, so I should point out that the central chemoreceptors are separate from the central controller. So within the medulla, there is a central controller, which we have talked about a minute ago, and there are also chemoreceptors, which are found in the medulla. The central chemoreceptors are located bilaterally near the ventrolateral surface of the medulla. These cells are in contact with the cerebral spinal fluid. So the central chemoreceptors respond to changes in the cerebral spinal fluid. The blood-brain barrier separates the cerebral spinal fluid from the arterial blood. This protects the cerebral spinal fluid from substances within the arterial blood, such as infection, for example. But the blood-brain barrier also affects the movement of bicarbonate and hydrogen ions between the blood and the cerebral spinal fluid. The physiology here is that CO2 easily diffuses from the arterial blood across the blood-brain barrier of the cerebral spinal fluid. So if your arterial PCO2 goes up, almost instantaneously, the PCO2 in the cerebral spinal fluid goes up as well. So changes in the arterial PCO2 result in changes in the PCO2 in the cerebral spinal fluid. That change in carbon dioxide in the cerebral spinal fluid changes the hydrogen ion concentration and the pH within the cerebral spinal fluid. The decrease in pH in the cerebral spinal fluid stimulates the central chemoreceptors to increase ventilation and vice versa. And I'll have an illustration of that, I think, on the next slide or the one after that. However, with a chronic change in PCO2, eventually the pH of the cerebrospinal fluid will return to normal. So in the short term, bicarbonate and hydrogen ions do not diffuse across the blood-brain barrier very well. But over time, they will, so that there will be an equilibration over time between the pH in the cerebrospinal fluid and the pH in the blood. So this illustrates anatomically what I was talking about a minute ago. So here is the blood, here is the cerebrospinal fluid, here is the blood-brain barrier. The blood-brain barrier serves to protect the brain from toxins, if you would, that occur in the blood. So, for example, if we get a bloodstream infection, the brain tends to be protected because those bacteria do not make it across the blood-brain barrier very well. CO2 moves across the blood-brain barrier very easily, whereas hydrogen ions and bicarbonate do not. So if the PCO2 goes up in the blood, the PCO2 will at the same time increase in the cerebrospinal fluid. That will increase the hydrogen ion concentration in the cerebrospinal fluid, lowering the pH and stimulating the central chemoreceptors. Over time, eventually, so with chronic hypoventilation or chronic hypoventilation, over time, bicarbonate and hydrogen ions will slowly diffuse into and out of the cerebrospinal fluid to restore the pH in the cerebrospinal fluid. So if we become acutely hypercapnic, that will stimulate the central chemoreceptors to cause us to breathe more. But if we continue to be hypercapnic over time, eventually bicarbonate will diffuse into the cerebrospinal fluid to restore the pH of the cerebrospinal fluid, and then the respiratory drive will go away.
Dean, do we know about what sort of time frame in these people say who have chronic respiratory alkalosis?
So this is instantaneous. This takes hours to days, probably a few days to be complete.
Thank you.
So initially, if right now I were to become acutely hypercapnic to a PCO2 of 60, I'd have a very strong drive to breathe because the CO2 very quickly makes it into the cerebrospinal fluid. If I kept my PCO2 at 60 over a few days, that drive to breathe would go away because the pH in the cerebrospinal fluid would normalize. And that's probably what you want, right?
Yeah.
So you would want to, if you had an acute increase in PCO2, you'd want to increase your ventilation to lower your PCO2. But if you can't do that because you have respiratory disease, for example, you would want your sensation of needing to breathe more to go away over time. So this just illustrates what happens. So if there's an increase in CO2 in the blood, that will almost instantaneously increase the CO2 in the cerebrospinal fluid. That decreases the pH in the cerebrospinal fluid, or that increases the hydrogen ion concentration in the cerebrospinal fluid, decreases the pH. That stimulates the central chemoreceptors. That then stimulates an increase in ventilation. So then when we breathe more, the PCO2 goes down, so the pH in the cerebrospinal fluid goes down, or the hydrogen ion concentration goes down, the pH goes up, there's a decreased stimulation to breathe, decreased ventilation, and everything reverts back to, hopefully, normal. In addition to the central chemoreceptors, there are also peripheral chemoreceptors. The peripheral chemoreceptors are the carotid bodies, here at the bifurcation of the common carotid artery, and the aortic bodies at the arch of the aorta. These peripheral chemoreceptors, the aortic and the carotid bodies, are stimulated by a decrease in PO2, a decrease in pH, and an increase in PCO2. The central chemoreceptors are affected only by changes in pH within the cerebral spinal fluid. The peripheral chemoreceptors are stimulated by changes in PO2, pH, and PCO2. And the response to stimulation of the peripheral chemoreceptors is to increase ventilation. And we'll look specifically at that in a few minutes. There are also receptors that affect the control of breathing. There are receptors within the lungs and also elsewhere in the body. In the lungs, perhaps the best known and most studied receptor is the pulmonary stretch receptor, which is sometimes called the Herring-Brewer reflex. So the Herring-Brewer reflex tends to oppose inflation or inhalation. So the more that we breathe in, the greater is the stimulation to stop breathing in. So this protects against overinflation, if you would. There are irritant receptors, such as noxious gas, cigarette smoke, dust, cold air. These cause hyperpnea and bronchoconstriction. We have probably all experienced that at some point or another. And then there are juxtacapillary receptors called J receptors, which are in the interstitium of the lungs and cause a rapid shallow breathing pattern. And it is thought that that may contribute to the tachypnea that we see with congestive heart failure and in patients with interstitial lung disease. So in patients who go into left heart failure or patients who have interstitial lung disease like pulmonary fibrosis, that stimulates the J receptors, which causes tachypnea. And then there are a number of nose and upper airway receptors. There are receptors within the joints and the muscles, which may be important for increasing ventilation during exercise. Baroreceptors, which are primarily important for hemodynamics, may have a role here, as well as pain and temperature. Now let's look at the integrated responses to carbon dioxide and oxygen on this slide and the next. Shown on this slide is the relationship between ventilation and changes in PCO2. In this study, they measured alveolar PCO2, but we can for now assume that that's the same as the arterial PCO2. Making the point that an increase in PCO2 causes a large increase in ventilation. Carbon dioxide is a very strong drive to breathe. In fact, increasing the PCO2 by only 1 millimeter of mercury will cause an increase in ventilation of 3 liters per minute. When the lab was actually on the other side of this wall, probably 20 years ago, we were doing some experiments where we would induce an increase in ventilation by breathing 3%, 5% carbon dioxide. And I can tell you on me, when my end tidal PCO2 got up to the mid-40s, I couldn't stand it anymore. I was breathing as fast and as hard as I could. In fact, I was running, except I wasn't running. So CO2 normally is a very strong drive to breathe. We are very protective of our arterial PCO2. A decrease in PCO2 below normal decreases the drive to breathe, so the opposite effect. And there's something called the apneic threshold, which is about 3 or 4 millimeters of mercury below the resting PCO2. So what does that mean? Well, if we lower our PCO2 to 30, what's going to happen to our ventilation? It'll be apneic. So now think about that patient who you come by to do your spontaneous breathing trial, and you have lowered their PCO2 to 35, let's say, and you switch them over to 0/0, and for a while they don't breathe until their PCO2 increases past the apneic threshold.
Is this similar to what happens when people with congestive failure and chain Stokes?
That is a more complicated thing, but it is sort of related to that.
Yeah.
So it is related to that. So what happens with congestive heart failure and stroke and Cheyne-Stokes breathing is that there is a heightened response. So it's called a loop gain problem, where you breathe fast, your PCO2 goes down, you stop breathing, and then your PCO2 goes up and you breathe fast. And for you and me, who don't have an issue with loop gain between our ventilation and our brainstem, that doesn't happen. But it happens if there is a reduced blood flow to the brainstem, which can occur with congestive heart failure or stroke. But that's sort of exactly what happens with congestive heart failure and Cheyne-Stokes. And we'll look at Cheyne-Stokes again in a few minutes. The CO2 response is also affected by PO2. So here's the relationship between ventilation and PCO2. If we have a PO2 of a little bit or higher than normal, but as we lower the alveolar and the arterial PCO2, the slope of the relationship increases. So your respiratory drive is greater if you have hypercapnia and hypoxia rather than hypercapnia just by itself. CO2 response is reduced during sleep, so that feeds into some of the issues with CO2 retention during sleep, but even normally, all of us, our PCO2 goes up a couple millimeters of mercury when we're asleep. CO2 response is reduced with opioids, propofol and barbiturates. More about that in a few minutes. And then the other thing is that there's a large inter-individual variability. So one person will respond to CO2 differently than another person, and one patient will respond differently than another patient. Here is the response to oxygen. So now here we're looking at the change in ventilation, looking at alveolar or arterial PO2, and you can see that the response to hypoxemia kicks in at a PO2 of about 60. So for any one of us, if we reduced our PO2 to less than 60, we have an increase in ventilation. And for some people, that is extremely uncomfortable. I don't know if any of you have ever been to high altitude and dropped your PO2 into the 40s and 50s, and you start puffing, particularly when you go up a flight of stairs. A few years ago, I was invited, fortunate for me, to Quito, Ecuador, which is very high. It's over a mile high. I forget how many feet it is. And my wife went along, and it really bothered her for about the first day until she acclimated a bit. Because at that altitude, our PO2s were probably around 50. This is also affected by PCO2. So as you can see, the slope of the relationship increases with PCO2. So if you have a PCO2 of 50, your hypoxic drive kicks in at a much higher PO2. So then clinically, what are some factors that affect respiratory drive? Well, things that increase respiratory drive are hypercapnia, acidosis, hypoxemia. We talked about these things. Pain, because of the effect of the cerebral cortex. Anxiety, because of the effect of the cerebral cortex. And then drugs like aspirin, xanthine. These are theophylline. So years ago, it was in vogue to administer patients theophylline to increase their respiratory drive. It didn't work very well. And they got upset stomachs and tachycardia and other issues. Progesterone increases respiratory drive, and dopram or doxapram, which again years ago was used to stimulate respiratory drive, again didn't work very well. Progesterone is interesting because that explains why pregnant women hyperventilate. So you may or may not know this, but if you draw a blick S on a woman who is, I think, around 6 to 9 months, third trimester, they have a low PCO2. Did you know that? And it's because of the progesterone effect during pregnancy.
I thought it was just, I did one on a break. I thought it was just going to hurt.
Oh, yeah, we didn't know. But yeah, normally in pregnancy, the individual women have a hyperventilate, and it's because of the progesterone effect. Things that decrease respiratory drive are hypocapnia, alkalosis, and then drugs such as narcotics, propofol, and barbiturates. And this sometimes can be helpful in the ICU, right? We administer narcotics and propofol sometimes to reduce respiratory drive. So here, I added this into the slides last evening, so it didn't make it into the handout. But here it just shows some of the abnormal breathing patterns that can occur. So I'll just talk about a few of these. So Biot's respirations are a very irregular breathing pattern that occurs primarily in patients with brain injury. So I suspect you see Biot's not uncommonly on Leonard 6. Cheyne-Stokes breathing, as we had already talked about, is the waxing increase and decrease in ventilation with periods of apnea. And a point that I want to make about actually a number of these breathing patterns is that they do not represent a problem with lung function. They represent another problem, and the lung is kind of the downstream effector. So as we talked about before, Cheyne-Stokes breathing occurs primarily in patients with congestive heart failure or with stroke. So if you see a patient with Cheyne-Stokes breathing, probably a pretty good bet that they have CHF or that they've had a stroke. Kussmaul's respirations are breathing as fast and deep as you can. So who do you see with Kussmaul's respiration?
DKA.
Pardon?
DKAs.
Yeah, a diabetic, yeah. So this is what the type of breathing pattern that occurs with the acidosis that occurs as a result of diabetes. So then, how can we assess respiratory drive? Well, one thing we could do is we could give you carbon dioxide and see how much you increase your ventilation. So we give you 3% carbon dioxide to breathe, and your minute ventilation doesn't change. There's a problem with your controlled breathing. We give you 3% oxygen and you start breathing as fast and deep as you can, that would indicate that you have some reasonable respiratory drive. We can measure occlusion pressure, which we'll talk about in a few minutes. Bob said, make sure you talk about P100, so that's occlusion pressure. So we'll talk about that. One of the things that I want to point out about ventilation response to CO2 to assess respiratory drive, or occlusion pressure to assess respiratory drive, is that it assumes that you or your patient has normal neuromuscular function. If you have ALS, you have motor neuron disease, you can have a really strong drive to breathe, but you're not going to increase your ventilation appropriately because the signal never makes it to the respiratory. Your P100 could be 0. If you are completely paralyzed, or in a patient with ALS who is on BiPAP or on and off the ventilator, their P100, they could have a very high respiratory drive and their P100 could be normal too.
So it's a perfect measurement of
neuromuscular apparatus. And the reason for that is you don't realize your airway is occluded until after 100 milliseconds. So you don't start breathing in harder until after 100 milliseconds. This reflects drive and strength, as we pointed out a minute ago. Normal value is -2 to -4 centimeters of water. I don't know what Bob told you. I didn't show these slides to Bob. Hopefully he told you the same thing.
about -2.
Yeah, so about -2 to -4. 0 to -2 is a weak drive or muscle weakness. There's your ALS patient. And more than -4, -5, -6, -7, -8, indicates an increased drive to breathe. And that increased drive to breathe will increase the work of breathing because it will cause you to contract your respiratory muscles more. One of the things that is pointed out over and over in the literature is that the reproducibility of the occlusion pressure is not good. So it's probably better to average 2 or 3 measurements rather than taking a single measurement. So on the ventilator, you press the button to do the occlusion pressure and you write down that number. Maybe it's better to do it 2 or 3 times and average rather than just taking one number. So with the occlusion pressure, you cannot adjust to increased load within 100 milliseconds of the onset of inspiration, as I already pointed out. On modern ventilators, the trigger delay on the ventilator is less than 100 milliseconds. So that will be imperceptible to most patients. So because unless you have the sensitivity set at -10 or at a flow of 10 liters per minute to trigger, if you have the trigger sensitivity set reasonably, most ventilators will trigger within 100 milliseconds, so it will be imperceptible to the patient. So if the patient perceives that they're not able to trigger the ventilator, it's usually not the engineering that's the problem, it's the physiology, like they have auto peak, for example. In non-intubated patients, P100 can be measured using a valve that occludes randomly at the end of exhalation and opens after 100 milliseconds of inspiration. And then on ventilators, we can measure or calculate the P100 because the inspiratory valve does not open immediately. And I believe, and maybe some of you know, and I should have asked Bob earlier today if he knows, but from what I could tell, reading in the literature and going through the manual for the PD 980, it is, I'm pretty sure, a calculated, estimated value. So what it does is it looks at the slope of pressure decrease as the patient triggers. And if the ventilator triggers at 60 milliseconds, it just extrapolates it down to 100 milliseconds. Do any of you know?
I was trying to find that out too.
I'm pretty sure. What I thought happened a couple of years ago when we first got the machines, I thought what happened was the ventilator changed the trigger sensitivity for that breath. But I don't think it does. I think what it does, and in the manual it talks about calculating the P100 and estimating the P100. So I'm pretty sure that what it does is for that breath, it extrapolates to 100 milliseconds because the response is relatively linear. So this is the relationship between P100 and workup breathing. Normal workup breathing is around 0.5 to 1 joule per liter. So when talking about PAV, for example, we talk about adjusting PAV to a workup breathing of around 0.5 to 1 joule per liter. And notice that that translates into a P100 of about -2 to -4. So that's where the -2 to -4 comes from for a target level of P100. And with a more negative P100, the workup breathing is increased. And this, I think, shows a couple of interesting things about the P100. So what this shows is that if we look at P100 for either of these two curves, as we increase the level of support, which runs from right to left, as we increase the level of support, the P100 goes down, which is what you would predict. The other interesting thing that was pointed out in this slide is that patients who have a higher P100 are more likely to fail their spontaneous breathing trial. So that would suggest if you have a high P100, you have a high workup breathing. A high workup breathing, you may be more likely to fail your SBT. So here are some guidelines, and I hope this fits with what Bob and other people told you. P100 ventilator support. This did not make your handout because I thought about this earlier this morning when I was reviewing my slides. So P100 of 0 to -2 means weakness, like ALS, paralysis, like if the patient's on Nimbex, their P100 will be 0, or they're getting too much support. So we've dialed up the ventilator, drove their PCO2 down to 30, below the apnea threshold. 2 to 3 is probably an adequate level of ventilator support. -4 to -5, consider an increase in the level of support. And with a P100 less than -5, -6, -7, -8, -9, we should increase the level of support, or we should do something to reduce the patient's respiratory drive. So this might be drugs sometimes. Is that consistent with what you were told? So I'm hoping, since Bob told me, make sure you talk about that. I'm giving you a consistent message. I was going to go over this with him earlier this morning, and then I forgot. So again, averaging several values rather than having a single isolated value is probably better. And the response to a change is maybe as important as an isolated value. So you get a P100 of -8 if you increase the level of pressure support. Does it go to -4, for example? Now, what about hypoxic drive in COPD? So if we give a patient with COPD who is hypercapnic oxygen, does that knock out their hypoxic drive and cause their PCO2 to go even higher? And the answer to that, I'm sure we all agree by now, is that it probably has little effect on hypoxic drive. And here's a study that was published many years ago, maybe before some of you were born, not me though. So this was published way back in 1980, where they took patients with COPD and they gave them oxygen, and they measured changes in their PCO2, in their ventilation, and their P100. So now we know P100 is drive to breathe. What did they find? Well, they gave them oxygen, and their PCO2 went up. We know that happens. They also found that their ventilation went down by a little bit, but not a whole lot. Went down by 14%. That's not a real big change in minute ventilation. And they measured the P100, and the P100 went from -8 to -5. So there was a lower drive to breathe when they gave them oxygen. But we now know that -5 is still a pretty strong drive to breathe. So giving patients with COPD oxygen, these data would suggest did not knock out their hypoxic drive because their P100s were still on the high end of the range even after they got oxygen. I used to say, and the commercials changed, so this doesn't make any sense anymore, but I used to say that COPD patients are like Toyotas. Remember the commercial, "We are driven"? COPD patients have a big drive to breathe. And it doesn't change that much if you give them oxygen. Okay, let me take a few minutes and talk a little bit about dyspnea, because dyspnea kind of falls in with a discussion of control of breathing. Dyspnea is a subjective experience of breathing discomfort. It is subjective, and the only way that you know that a patient is dyspneic is if they tell you that they're short of breath. So it's like pain in that regard. So the only way that you know that somebody's in pain is they tell you you're in pain. And there's a lot of variability from individual to individual. So two individuals can have the same work of breathing, and one of them says they have no dyspnea at all, and the other one says I can't hardly breathe. This can only be perceived by the person experiencing it. It is commonly described as an increase in effort to breathe. So this would be like the patient with COPD who has altered respiratory mechanics. Or it could be the sensation of air hunger, which is an increased respiratory drive, which we all would appreciate if we breathe in carbon dioxide. It's important to appreciate that dyspnea and tachypnea are two different things. So just because a patient is tachypnic does not mean they're short of breath. The only way we know they're short of breath is we ask them, are you short of breath? Maybe they are, maybe they are not. And dyspnea and asynchrony are two different things. So we look at the patient is asynchronous, we all agree the patient is asynchronous. Doesn't mean the patient's short of breath, doesn't even mean the patient's uncomfortable, because those are subjective things that the patient would need to tell us. There are ways that we can measure dyspnea, so this is commonly used to assess patients with stable COPD, to evaluate their functional status. I don't know if you've gotten into this at all, but this is part of the GOLD guidelines to assess functional status of COPD. One can also use the Borg scale to measure changes in dyspnea with an intervention. So, for example, the Borg scale might be used during a 6-minute walk test in COPD to see if the dyspnea becomes greater when a patient is walking. So your patient tells you that they are short of breath. So you ask the patient, are you short of breath? It's bringing back memories of that chart that we made up in the MICU that never went anywhere. So Ernie designed this really cool chart so we could ask patients on a scale of, it was on a line, visual analog, and they were going to point and tell us how short of breath they were. So your patient tells you that they're very short of breath. So how can we address that? Well, we can do things to decrease the load on the respiratory muscles, bronchodilators, airway clearance, diuresis, antibiotics, or increase the level of ventilatory support. This does not work the majority of the time, as we'll see some data in a minute. Or we can use pharmacology, like narcotics, which depress respiratory drive and reduce dyspnea. And it does that by separate mechanisms, by the way. So the effect of narcotics on respiratory drive and dyspnea are separate from one another. And another thing that is effective in some patients is nebulized Lasix. And I don't know if you've done that recently, but I know when I was still around, we were doing that from time to time on patients with dyspnea. So this one did not make it into your handout because I thought about this last evening. I thought, oh, this needs to be in the lecture tomorrow. This is a paper published a few years ago, back in 2011, looking at dyspnea in mechanically ventilated critically ill patients. They actually had a scoring system where they asked patients what their level of dyspnea was, and the patients reported whether or not they were dyspneic. What they found was that about half of the nearly 100 patients in the study said that they had dyspnea. Some of them said it was because of an increased effort to breathe, some of them said it was air hunger, some said they had both, some said they didn't know. They found that dyspnea was associated with two primary factors: anxiety, that's not surprising, and being on assist-controlled ventilation. Maybe that's surprising, maybe that's not surprising, but these were the two most common reasons that were associated with dyspnea. Interestingly, they said, well, if assist-controlled ventilation is associated with dyspnea, what happens if we change the ventilator settings? What happens if we increase the respiratory rate, increase the tidal volume, decrease the peak, put them on pressure support, put them on pressure, try all kinds of different things, like we do sometimes. They found that adjusting the ventilator settings improved dyspnea in only 35% of the patients, and only about a third of them. And in fact, in about 2/3 of patients, changing the ventilator settings did not affect their dyspnea. Now, I think that it's worth in a patient who's complaining of dyspnea to try to adjust the ventilator to see if you can make it better. 1 out of 3, you may be able to make it better, but 2 out of 3, changing the ventilator settings may not affect their level of dyspnea. Interestingly, and unfortunately, in this study, they did not report pharmacologic interventions. So we don't know. What if they would have given them some anxiolytic? I mean, the most common reason for dyspnea was anxiety. What if they treated their anxiety? And they did not do that in this study. Okay, in summary then. The central chemoreceptors respond to changes in the pH of the cerebral spinal fluid in response to changes in the, should have an A there, arterial PCO2. Peripheral chemoreceptors are stimulated by a decrease in PO2, a decrease in pH, and an increase in PCO2. The cerebral cortex and receptors affect respiratory control. An increase in PCO2 is a very strong drive to breathe. Hypoxic drive kicks in at a PO2 of less than 60 millimeters of mercury. The P.1 or the P100 assesses respiratory drive, and dyspnea is something that I think we should assess in mechanically ventilated patients. And it's too bad we never did that project in the MICU. after you did that. Made that really cold. Well, I guess the problem was that this was driven by one of the senior residents, and when she matched for fellowship, she decided to go to Penn rather than stick around in the study probably was done. Okay, so that concludes the series on respiratory physiology. Now, one thing I had suggested to Bob is I could just start over again because not everybody has come. Nancy, were you at all the talks? You might have been.
No, I was at a lot of them.
Yeah, so, and I don't even think Ed was at all of them.
And this one.
Yeah, so we could redo them, and maybe different people would show up the next time. But Bob said, well, no, maybe I think we should do something different. But we haven't figured out what we'd do differently for lectures going forward. So if you have any suggestions, let me know. That we should prone early patients with ARDS. And in fact, the study, the most recent randomized controlled study that a lot of people point to, showing a survival benefit, oxygenation improvement and survival benefit with prone. They proned patients when they had a PO2, FiO2 of 150 or less on a PEEP of 10. And I would argue that in many of those patients, if they would have patients with PF ratio of less than 150, they would have gotten them up to a PEEP of 15, 18, or 20. They probably wouldn't have had a PF ratio less than 150 anymore. So I think that prone has a place. I'm actually part of a guidelines committee that is going to publish some guidelines about this soon. And where we came down on this is that we make a conditional recommendation for the use of prone, but doing an adequate lung recruitment and PEEP titration first.
And I think that's
Bob,
key. I mean, I think Dean said it. You should be recruiting the lung, you should be setting the PEEP properly, and if that doesn't work, then I would agree you should prone the patient. But in both cases, this should be done very quickly. I mean, the mistake that everybody makes is whether it's recruiting and setting PEEP properly or proning is waiting too long into the disease process. I mean, once you get the patient stabilized, then we should recruit and we should set PEEP. And if in a few hours we don't see the kind of change we expect, we ought to go right to proning that patient. Waiting is not going to serve the patient any benefit.
So I can tell you, so I don't know what's happened with prone around here and in MICU and so forth in the last 6 months, but when the paper came out in the New England Journal a couple of years ago, 3 years ago now probably,
Yeah, maybe longer.
showing a benefit for prone in patients with ARDS in regards to survival, I expected that we were going to be proning a lot more patients. And after 6 or 8 months or so, it occurred to me, proned hardly anybody since that paper came out. And we're not proning patients any more than we ever did before. And then it occurred to me that the difference is that take patients with severe ARDS, MICU and other units around the house, and they'd be on 18, 20, 22 of PEEP. They wouldn't be on 10 of PEEP like was done in the study. So once they got recruited as well as they could and got their PEEP set where it should be, then all of a sudden prone gets taken off of the table.
Yeah, that's exactly the practice now in the NICU. We've proned a couple of patients the past couple of months, but more often than not, they respond to recruitment maneuver and adequate PEEP titration, and the proning, as you said, is no longer considered.
Yeah.
But there was one patient who did, in fact, do it that way. Recruited him, did a PEEP titration, and it still ended up proning. And there was a change in oxygenation.
Yeah, well, there are some patients that are not recruitable.
So the other thing I think you ought to remember, if you look at that trial that Dean's talking about, that prone positioning trial, if I remember correctly, the mortality in the prone group was 16%. the mortality
That's right.
in the control group was 30 or 32%. Nobody has ever shown that kind of mortality in ARDS patients. So I believe, based on the way they manage them, the inappropriately low levels of peak, that they were recruiting patients who really weren't that sick. And I'm not saying prone hurt them, because obviously it didn't hurt them, but I'm not sure that they were dealing with the same level of ARDS that we're talking about we consider proning patients.
Yeah, one of my rules of interpreting a study, a randomized control trial, is if the results are too good to be true,
They're probably too
they're probably too good to be true.
Agreed.
Dean, how much change in blood flow do you get when you prone a patient who already has significant lung disease?
Already has what?
Significant lung disease, so our ARDS patient
Yeah.
who we're going to prone.
Yeah.
How much of the effect do you think is attributed to change in perfusion versus recruitment?
So it's so some of it's change in DQ and some of it is recruitment. I'm trying to remember if there's. I think it's still in review. I reviewed a paper for another journal recently on oxygenation effects of prones, and it's actually done by Rob Glennie and really smart people. And they make the point that there are multiple reasons for the improvement in oxygenation, and it's probably all of them together. Now, in an individual patient, one may be more predominant than another, but they actually made a big case about the VQ matching, and that's actually where I got the idea to draw this slide the way that I did. But it's not. I certainly don't want to communicate that it's only VQ. So some of it is recruitment as well.
So you also know when we first started talking about prone positioning, people thought when we prone patients, we changed the distribution of perfusion so much so that we altered it from the normal relationship. But as Dean showed, there is a change in the slope, but you still have that same gradient that exists.
Yeah, it's probably more how the VQ changes than the ventilation or the perfusion by itself.
Right. There's a perception that when you flip these patients, all the blood flow now goes to the anterior segments, and you have less damage than right. So that's why I wanted to bring it up.
Yeah, and in fact, it's been shown on CT studies from many years ago that when you prone patients with ARDS, what was the dorsal consolidation becomes the ventral consolidation. So which would argue for things like VQ and other things.
Well, for that, and just the change in the superimposed pressure of the heart, the great vessels, and the fluid being now shifted from the dorsal to the ventral. So there's less compression
of the ventral lung in a prone position.
Right, so that just opens things up when you put them. So you have a greater percentage of the lung, anterior, and as a result, that's not going to consolidate as often, so you have a greater surface area for gas exchange, and it usually improves. I mean, it's rare to see a patient prone without some improvement in oxygenation.
Okay.
Thank you,
Next
Dean.
time, I think we talk about blood flow.
According to, again, assuming vascular volume is okay, that should be the case, or that the patient has no significant cardiac problems. Now, if somebody's got significant cardiac problems, maybe not, but if they're reasonably stable cardiac-wise and got good vascular volume, they should be okay.
Yeah, I mean, I illustrated the effect of hypovolemia, which is also to reduce the diameter of the pulmonary capillary to increase PPR.
Right.
Yes, see.
What's the cost of Voletree for the day versus nitrate for the day?
About a 20-to-1 difference.
20 to 1?
Yep.
Okay.
Voletree, Dan, help me here. Voletree, I think, costs $100.
$200 a day for Voletree.
Right.
200, okay.
It's $150 an hour for nitric.
Right. I used to say,
Per hour?
when I would be asked this question,
So figure it out, it's about a 20-to-1.
Wow.
yeah, when I was asked this,
It was pricey.